All right, it's noon in Arizona, so we're going to stick to our timetable and just begin by saying welcome to everyone who's joined. We've got so far more than 60 folks who've joined from around the country to join us for this incredible health talks. I'm your moderator for the day, Mike Yudell. I'm the interim dean and professor in the College of Health Solutions here at Arizona State University. My research actually focuses on some of the topics we're going to explore today. So I am really delighted to serve as my moderator for this session, Autism at All Ages, Updates and Resources. Now, at the College of Health Solutions, we work towards addressing the challenges facing people and communities to stay healthy, improve their health, and manage chronic disease. And these health talks are one way we serve the community with timely and relevant educational information that also provides continuing education credit at no cost. Before we begin, a few quick housekeeping items. First, this session is being recorded and we will post it on our website at asuhealthtalks.com. After the panelist presentations, I will moderate probably about a 15-minute Q&A session, and please remember to submit any questions you have using Zoom's Q&A feature, and don't put them in the chat box. I won't be able to see those. And make sure you get credit for attending today's session by using the self-check-in link posted in the chat. Finally, you will receive a brief survey asking for your input about today's webinar. If you are requesting continuing education credits, this must be completed in order to receive credit. If you did not apply for CEUs, we would still appreciate your feedback to improve our series. Before I introduce our speakers, just want to say a bit about the work that they do and that we do here at ASU in the autism space, led by Dr. Braden, who you'll meet in a few moments. We are working towards positioning the College of Health Solutions as a leader both in Arizona and nationally in the space of thinking about autistic people throughout the lifespan. We've been having discussions about building more resources and infrastructure that will focus on this particular issue, particularly around health, education, and housing across the lifespan for autistic people. So if you have more questions about that, please reach out to me or Dr. Braden after the talk via email, and we'd be happy to discuss some of the things we're thinking about. So with that said, I'm really excited to introduce our two speakers. First, Dr. Nicole Matthews, who is a developmental psychologist and the director of research at the Southwest Autism Research and Resource Center, a nonprofit organization in Phoenix. Nicole's research focuses on improving quality of life for autistic individuals through improved detection and diagnostic processes and the development of evidence-based support programs. After Nicole speaks, Dr. Blair Braden will join us. Dr. Braden is an associate professor here at the College of Health Solutions and the director of the Autism and Brain Aging Lab. She also co-leads our autism translational team, which brings together scientists and scholars from across our college and the university and the community to think about how to translate findings in autism research more broadly. She earned her PhD in behavioral neuroscience from ASU and completed her postdoc at the Barrow Neurological Institute in Neuroimaging and Neuropsychology. So we are really grateful to have these incredible experts with us today as we explore autism at all ages, updates, and resources. As we know, autism is not a one-size-fits-all disorder at any age. And in today's webinar, you'll get a high-level look at the history of autism and how the diagnosis and definitions have changed over the years. You'll learn about aging with autism and what resources are available in the community for living with autism at all ages, including ongoing research and information offered by SARC, and our health experts will help you grow your understanding of autism and the resources you need to know. So with that, let's kick it over to our first presenter, Nicole Matthews, who will be talking about autism screening, diagnosis, and intervention in children and adolescents. Nicole, thank you so much for being with us today.
Right. Well, thank you, Dr. Yudell. I appreciate that. I appreciate everyone for joining us. See if I'm getting my screen set up correctly. Does that look right?
Yes, that looks right.
Excellent. Well, I'm going to get us started by doing a high-level overview on autism screening, diagnosis, and intervention in children and adolescents, and a little bit on young adults. And this is truly high level. It's as much as I can share in about 15 minutes, which is the time I have. Like Dr. Yudell shared, I am the Director of Research at SARC. We are a nonprofit organization in Arizona, predominantly in the Phoenix metropolitan area, although we have a goal of being a statewide organization by 2030. And for those of you who are local, I will be providing a brief overview at the end of the services that we provide in case you are looking for those types of services. So I will start by talking about screening and diagnosis throughout childhood. Then I will do a brief summary of interventions for children, adolescents, and young adults. And then last, talk about resources and support that are available at SARC. So before I get started, I do want to make sure we're all on the same page about what we're talking about when we say autism spectrum disorder. So by definition, individuals who have an autism diagnosis experience challenges with social communication and also restricted and repetitive behaviors and interests. And these challenges must result in some type of functional impairment. The name autism spectrum disorder indicates that it is indeed a spectrum condition. So at SARC, we like to say if you've met one person with autism, you have met one person with autism. And that's because these challenges can present themselves in many different ways. So just taking socialization, for example, a common stereotype is that people on the autism spectrum do not desire social relationships. And although this is true for some, it certainly is not the case for all individuals who have an autism diagnosis. Many have a strong desire for social relationships, but might face challenges establishing them or maintaining them. And so it's really important to think about this complexity when we think about diagnosis, because it does contribute to some of the challenges with identifying autism early and providing resources and supports to people who may need them. So a couple of years ago, the Centers for Disease Control prevalence estimates indicated that the median age of diagnosis in the United States is about 49 months and a little bit higher in Arizona. So between 4 and 5 years, essentially. But we know that we can diagnose autism much earlier than that in a lot of children. So there is some research indicating that autism can be diagnosed as young as 12 months in some kids, although the diagnosis at 12 months is not necessarily as stable as diagnosis provided a little bit later in the second year of life. It's rare to be able to diagnose a child this young. And I will say anecdotally, when we see this at SARC, it tends to be children who have an older sibling who already has a diagnosis, and the parents are perhaps already on the lookout for signs and symptoms and maybe already checked in to the services system. A study published by 2019 by one of our collaborators, Dr. Karen Pierce at UC San Diego, actually looked at the stability of diagnosis of children who received a diagnosis in the second year of life. This was in a sample of 1,000 children, and they found that stability of children who received their diagnosis by 14 months of age is actually quite high. So between 14 and 24 months, if a child receives a diagnosis, they tend to keep that diagnosis over time. However, there are many children who get evaluated in this age period who do not receive a diagnosis, but they may meet diagnostic criteria by 36 months or even later. So we have a lot of research that suggests that there are many children who get comprehensive evaluations in the early childhood period, and they may show features of autism or they may show social challenges, but they don't meet full diagnostic criteria until a later age. And generally what happens is the social environment gets more complex as we age. And so these kids tend to have enough skills to sort of not have functional impairment until they reach an older age and the environmental demands exceed their abilities. So one way that the field has tried to address this discrepancy between the age where we know we can diagnose a lot of kids with autism and the average age of diagnosis is through early universal screening. So the American Academy of Pediatrics recommends universal screening at 18 and 24 months, as long as ongoing surveillance during childhood. And They do not recommend a specific screener, but perhaps the most commonly used screener is an autism-specific screener called the MCHAT. And this screener is validated for children as young as 18 months. However, we know that we can diagnose some children earlier. And so a few years ago, SARC undertook a collaboration with our collaborators at UC San Diego to deliver the Get Set model in Phoenix. So SET stands for screening, evaluation, and treatment. And the idea is to screen children, get them evaluated early, and roll them into treatment as early as possible so that they can take advantage of early intervention. So through this model, children are screened multiple times at 12, 18, and 24 months using a different screener. It's called the CSBS Infant Toddler Checklist. And what's nice about this screener is it is validated for children as young as 12 months of age. So this paper actually describes the results of that project. We recruited more than 100 pediatricians in the Phoenix area who all agreed to universally screen. And over 4 years, they conducted 45,000 screeners. We encouraged all of those pediatricians to refer any child that was identified by that screener. And through that study, 330 children received an autism diagnosis with an average age of diagnosis of 22 months. So much better than our state's median diagnosis, which is 57 months. However, we know that we were missing a lot of kids in that study. So when we look at the prevalence of kids who received a diagnosis among those who were screened, it was about 1%. And CDC estimates indicate that among 8-year-olds, it's actually 2.8%. So although screening can be effective at identifying children really early, we're still missing kids. And so that's why we are big proponents of ongoing screening throughout childhood. So why are we missing a lot of kids through early screening? Most validated screeners are far from perfect. So they miss a lot of children. That doesn't take away from the benefits that they bring. They are good at identifying children who have clear symptoms and whose parents can report those symptoms. Some other challenges we see is inconsistent referrals. So even though we encourage pediatricians to refer every child who was identified by the screener as having developmental delays, they didn't for various reasons. And then also some challenges with family follow through. So if they were referred, it didn't guarantee that families would actually follow up and get this diagnostic evaluation. Something also that we often see is that parents experience a sort of false confidence when their child passes a screener, even when concerns come up after that screener is administered. So they feel like, oh, they're in the clear because they passed the screener. So for all of these reasons, we know there is an increased need for awareness about the fact that autism often does not get diagnosed in early childhood. And when this happens, there's a risk for misdiagnosis of another condition or of co-occurring conditions. There is some research to suggest that people who are diagnosed later in childhood or adolescence or adulthood tend to have a higher prevalence of co-occurring conditions like anxiety and depression. And it's thought that some of this might be due to not having adequate support when they were younger. So to address this challenge, you could say, we developed a screener called the Social Challenges Screening Questionnaire for school-age children. And we did this by interviewing individuals who were diagnosed at 6 years or later, and also their caregivers, to ask them what were their first differences from their peers. And we essentially took any behavior that was identified by the majority of the sample and considered it as an item for this screener. The screener is on the right side of your screen. It is pretty simple to complete. It has clearly observable behaviors, and it can be completed by a parent or a teacher in 5 minutes or less. And we actually made this screener available for free to anyone. So anyone watching right now who wants to learn more about it, maybe you are a teacher, or maybe you're a parent with concerns about your child's development, you can go to the App Store and download this Think Autism Screener. And what's really nice about it is the app has resources for every single US state. So if you do have a child who's identified by the screener, then it will connect you or provide you resources for support in your area. Okay, so we talked about screening and diagnosis. Now let's touch a little bit on intervention. So this quote is actually from the Lancet Commission on the State of Autism Research and Clinical Services that came out in 2021. And what it's really getting at is that intervention for autism is not one size fits all, and it can't just be done at one point in time. So there's a lot of talk about early intervention and the benefits of early intervention, but there can sometimes be a conception that after a child exits early intervention that perhaps they don't need any more supports, when in fact many individuals on the spectrum need supports throughout the lifespan. And they depict that with this image, which is also in that article. And I hope you can see my mouse, but basically what they are trying to depict here is that individuals with more positive outcomes tend to have access to individualized services throughout the lifespan, whereas individuals who have less positive outcomes may miss out on individualized services for a variety of reasons. This article also came out in 2021, and what's nice about this article is it's publicly accessible, so anyone watching can go and Google this title. And it is the third version of a review of the literature to identify evidence-based interventions. So basically this group has stringent criteria as to what qualifies as evidence-based. So the research study should have a good quality design, and the findings should indicate positive benefits for autistic individuals. And in this most recent iteration, they identified 32 evidence-based practices. That number is a little bit deceiving because many of them fall under the umbrella of applied behavioral analysis, but there are quite a few, and they are all behavioral interventions that are considered evidence-based. So if there's anyone watching who is looking for evidence-based intervention for themselves or for their children, I would encourage you to go check this article out. This table is also from that article, and it is highlighting the manualized evidence-based interventions that they identified. And the reason I'm sharing this is because we actually use 2 of these interventions at SARC, so I'm going to tell you a little bit more about them. The first is pivotal response training, and this is actually a derivative of ABA. However, it is delivered in a much more naturalistic way. So the idea behind PRT is that you are modifying the environment to better support development of the individual, and also focusing on that individual's motivations and following their lead. So using what is naturally motivating for them to help reinforce the development of skills. And when PRT is done right, it really looks like play. So it's a far cry from what sort of early ABA looked like. And the majority of our clinical services at SARC are based on PRT for children starting as young as about 15 months, all the way through adulthood. The second intervention I wanted to highlight is the PEERS program. So this is a program developed out of UCLA for teens and young adults. And it focuses on teaching social skills. And what's important about this program is it's focused on individuals who want to learn strategies for making and keeping friends. So one of the first questions that we ask people who are enrolling or are considering enrolling in the program is, do you want to learn these strategies? Because there are many autistic individuals who don't, and that's okay. And so we don't want to force anyone to go into a program like this if these are not skills that they're desiring. This is a program that's based in cognitive behavioral therapy approaches. It's a 16-week group-based program, and usually a parent or some other caregiver or family member participates with the individual. I think Blair might touch a little bit more on PEERS in her talk, so I'm going to go ahead and leave it at that. Last, I just wanted to highlight services and support at SARC. So to fully go through this slide could take me a full 15 minutes, so I'm not going to be able to, but I have bolded the family resource team because they are such a valuable resource. I always am giving out their phone number and their contact information because their job is to talk to families or individuals about our services and support. So as you can see on this slide, we have programs for people who are just getting their diagnosis all the way through adulthood and late adulthood. So they can definitely advise you on what services you might want to check out. And they're also really great at providing information about services throughout Arizona, not just those provided at SARC. if you want to reach out to them, this is how I recommend you do it. So our website is autismcenter.org. And if you go to our website and click the request services button, you'll be able to fill out a form and they will contact you. Or you can contact them the old fashioned way using their phone number. I can go ahead and put these in the chat when I am done so that you guys can have access to them. So in summary, autism can be diagnosed in the second year of life, but we know that many children are diagnosed much later or maybe misdiagnosed. Although ASD screeners are great, they do miss a lot of children. So we encourage repeated screening throughout childhood. And really when a parent or caregiver asks me about concerns they might have about their child's development, I encourage them to get an evaluation or to pursue an evaluation regardless of the results of a screener they may have completed. There are several evidence-based interventions for children and adolescents, and SARC offers a few of them. So if anyone's looking for services, we would love to talk a little bit more about it with you. And that's all I have. Thank you all for listening, and I will turn it back over to Dr. Yudell.
Thank you, Dr. Matthews, for a fascinating and wonderful talk. You're getting lots of virtual applause and hearts, so the audience appreciates the things you've been talking about. I will now turn it over to Dr. Braden. Blair, take it away.
All right. Let me share my screen, hopefully seamlessly. All right, how's that? Okay.
It looks good. And can I just jump in to just remind people that if they haven't already done so, please, if you want CEU credit today, make sure you click the self-check-in link posted in the chat. All right, Blair, back to you. Sorry.
Thanks. No, important updates. So I'm going to kind of jump off where Nicole left off at young adulthood and talk more about autism across the adult lifespan. To put into perspective why this research is important and why we know so little about autism in older ages, I want to kind of walk you through a timeline of how and when autism came to be. It was initially named in 1943 in a paper by Leo Kanner and took kind of a shocking nearly 40 years before it actually became a diagnosable condition in the DSM. And then most of us are aware of this trajectory of autism prevalence, where back in 1980s, it was thought to be a rare condition, and now it's one of the most common developmental disorders, with 1 in 36 being the most recent prevalence in the US. But I want to take you back to that first paper that Leo Kanner published, and case number 1 was a kid named Donald Triplett, and he actually just died last year at the age of 89. So if the first life course of the first autistic kid ever identified just completed, it really helps you appreciate how little we know about the life course of autistic individuals. So in 2011, a group of experts gathered to talk about how kids with autism are growing up to be adults, and those adults are living likely full lifespans, and we need to know more about how aging may impact them. And during this time, the community was starting to be more vocal about their fears about growing old in a world where people don't particularly know how to take care of older autistic adults. And this is something we hear from parents a lot: what's going to happen to my kid when I'm no longer here to take care of them? And then 10 years after that original paper about how this is something we need to be paying attention to, a kind of bombshell paper came out using national Medicaid data that showed autistic adults were 2.6 times more likely to be diagnosed with early onset Alzheimer's disease or related dementia. And my lab here at ASU has been kind of working in the background over the last decade to try to address these issues of understanding cognitive and brain aging in autistic adults. And then when we identify areas that seem to be persistently challenging or declining, what can we offer to support? So we've been running this longitudinal study, like I said, for about 10 years. And we were one of the first to venture out in this direction in the autism world. And we've had a lot of great support from funders over the year, mostly funded by NIH now, but initially funded through the Arizona Department of Health Services and the Department of Defense. So this is kind of a dense table, but this shows you numerically where we're at with the size and the scope of our study. We have about half of our participants who are autistic and about half who are not autistic, who we've traditionally called neurotypical, but not so sure that that's the appropriate name anymore. But suffice to say, they're not autistic. However, we try to match them as much as we can to our autistic participants. These are people that are over the age of 40 that we follow longitudinally. The average age is low to mid 50s. We have about a 3-to-2 male to female ratio, which represents larger representation of autistic women than most research, which is something we worked very hard for. At this point, about 100 people we've followed at least once over time, but some people we've followed them for 8 years, getting 4 time points of data. Our participants at this stage do not have intellectual disability, so average IQ functioning, and then everyone who's in the autism group has their diagnoses confirmed by a measurement called the ADOS. So this is another way to look at the participants in our study, where we have age on the x-axis and a number of participants on the y-axis. And you can see we have these individual dots at ages 18 to 39. So these are young adults that we got just 1 time point of data on. And then anyone over the age of 40 in our study, we try to get them to come back every 2 years for cognitive and brain assessments. So you can see where we were in 2022, where we're planning to be in 2028, where we just keep getting more and more data on the same people over time. And I'm going to show you a little bit of data of some of our most striking findings. So in the question about longitudinal cognitive aging trajectories, and if there are differences between autistic and non-autistic individuals, the findings that have jumped out most prominently for us are in the area of memory. So this first finding was verbal short-term memory, where we had participants assessed at baseline and then had them assessed 2 to 3 years later. So we can calculate if there's change over that time. And if that change indicates that someone's improving, which is not often what we see in middle age, or if someone's clinically declining. And what this graph shows you is that when you look at the participants grouped in this decline versus stable versus improvement, first of all, we don't have many people improving, which is what we would expect. We do have most people as stable, which is also what we would expect. However, significantly more of our middle-aged and older autistic adults showed this clinically meaningful decline. So about 1/3 of the autistic participants, whereas only 1 neurotypical participant showed this decline. So that is kind of a worrisome finding. And then when we followed participants for another couple of years, we started to see this difference in trajectory for a long-term memory measure. So here now on the x-axis, we have time, and on the y-axis, we have performance. And that gray and black line at the top is the average performance of neurotypical adults, which is pretty stable across this middle-age time frame. But on average now, our autistic adults are showing a decline slope. And when you look at all those individual participant lines in the background, you can see there's a lot of variability. So not every autistic adult is experiencing this decline in memory performance, but a significant percentage of them are. Now, I'm not going to bore you too much with brain details, but there's one really important finding that I wanted to touch on, and this is the brain region that's most important for how we make our memories, how we form our memories, and it's called the hippocampus. So if we're seeing memory impairment in someone's behavioral test, it really confirms those findings when we see changes in the memory brain structure that align. And that's what we see here. So we measure the size of the hippocampus, which we know the hippocampus gets smaller as we age, and we wanted to see if that was happening maybe earlier or faster in our autistic adults. So again, we have time on the x-axis here and the size of the hippocampus on the y-axis. The neurotypical participants, their hippocampal volume's pretty stable across time, that gray and black line up at the top. But our autistic participants are showing this slightly faster decline in hippocampal volume at an earlier age than we would necessarily expect. So our middle-aged neurotypical participants, their hippocampi will shrink eventually, but probably not until they become quite a bit older. Some of the other really key findings that have popped out from our longitudinal aging study are in areas of mental health. And this is probably the most consistent finding in all of the adult autism literature, is challenges with mental health and reduced quality of life. So we see this in this graph in both of our autistic men and women reporting lower mental health related quality of life compared to our neurotypical men and women. And then lastly, in the realm of social communication. So as Nicole said, this is a core challenge for autistic individuals that can manifest in many different ways. But in our study, we asked participants to tell us to self-report about their social communication challenges. And in some areas of social communication, our middle-aged participants over here in blue, that were 40 to 70 years old at this time, reported significantly more challenges than our young adult autistic participants. So higher values here mean more challenges. So that just breezes through 10 years of work in about 5 minutes, but really points us to some specific areas that autistic adults are experiencing persistent and in some cases worsening challenges. So the 3 domains that we see popping out in our data are cognition, mental health, and social communication. But I've also highlighted some publications here at the bottom where other researchers are pointing to these findings as well in cohorts around the world. So picking up where Nicole left off about services for autistic individuals, there's this common phrase in the autism world called the services cliff. And this basically means when autistic individuals age out of the school system, there are very few systematic supports in place for them. And in particular, supports designed for autistic adults beyond young adulthood are nearly non-existent. So this is what we want to try to address. This is a strong aim of our lab, and our initial work in this area has been with mental health. So about 5 years ago, 6 years ago, we started evaluating a program called mindfulness-based stress reduction. So this was created from John Kabat-Zinn out of Harvard in the late 1970s. The overarching theme of MBSR is to teach adaptive coping skills where you redirect your focus to the present moment, and you do that with a non-judgmental attitude. In practice, this is an 8-week program where you meet once a week for about 2 weeks and you do daily meditation homework over the course of the program. So MBSR has been widely used in many clinical and non-clinical populations. A meta-analysis from 2017 compiled 142 studies across 12,000 participants where very consistent benefits are found. However, when we first started this work, not much had been done to evaluate MBSR for benefiting autistic adults' mental health challenges. So to breeze through about 5 more years of work, we have published time and time again that MBSR is a useful approach for autistic adults to improve their mental health. And even more profound, perhaps, is that during the pandemic, when we could no longer run these in-person groups, we recruited a national sample of autistic adults who we gave access to a mindfulness app called 10% Happier, and showed even just using an app for 10 minutes a day led to depression reduction in comparison to a group that was not using the app. Okay, so mental health. We have an approach that works well for autistic adults, but how do we address the persistent social and cognitive challenges, which has been much more daunting? And part of the reason is because nearly all of the evidence-based autism social programs that Nicole mentioned focus on children, teens, and at best, young adults. So it really remained to be determined if we could adapt these programs for autistic adults of any age. And then on the cognition side, there are programs that are created to provide cognitive support, but these mostly target neurotypical adults and with no specificity to the challenges that autistic adults face. So can we adapt these to work for autistic adults is another open question. And engaging in something so daunting, it became very important to our team that we work with the autism community in this regard. And this is an approach that Michael does a lot of research on called participatory research, where we work with autistic scientists, autistic students, and the participants in our study as well to guide the development of our support programs. So the end result of the program that we developed to address these 3 issues, we call the Strengthening Skills Program. And this pilot study was funded also by the Department of Defense. So to show you how we address each 3 areas, for mental health, our We use inspiration from the mindfulness programs we had previously evaluated. To address social challenges, we adapted peers content that Nicole mentioned. And to address cognitive challenges, we loosely adapted a program that was developed by Mayo Clinic called Habit that I'll talk a little bit more about. So peers adaptations that we did working very closely with Nicole were mostly about changing language to be more neurodiversity affirming, and making the approach more applicable to adults who are middle age and older and really not needing the same pedagogical strategies as children. It also was very important for us to mitigate power dynamics between the autistic participant and the partner that joined them in the program. So some examples of changes is, instead of calling this a social skills training program, we framed it as deconstructing social interactions, so that this gives autistic adults more insight into what's happening so that they can make choices in how they want to engage in an interaction to benefit them. And participants were also encouraged to share their own strategies. We really wanted to capitalize on the group learning and the rich experience of so many autistic adults who have developed amazing strategies of success, really largely on their own. Now, a little bit about the Habit program. It's called Habit, standing for Healthy Action to Benefit Independence and Thinking, and it was designed for individuals with mild cognitive impairment. So some of the things we changed for our approach is we made our approach very flexible so that participants could identify their own areas that they wanted to work on, and we call this a strength-based approach. We did have consistent topics that we worked through with every group, things like habit formation, time management, energy accounting, effective communication, autistic burnout, sleep hygiene, and finances. And similar to peers, there was a lot of group discussion and how these techniques were being used in everyday life and sharing strategies. And very importantly, it wasn't just the autistic adults who were working on these improvements, it was also their partners, and it was also the facilitators. So really, really emphasizing that we can all work to improve our quality of life. So from an experimental design perspective, this is how our pilot study ran. There was one group that received all three aspects to the intervention, the full strengthening skills program, and one group that received just the peers adapted content. And this was the manual that we were following most closely as to what is offered in the autism community. And then finally, a third group was the delayed treatment control. The program was delivered during the pandemic over Zoom. We had a neuropsychologist that led the cognitive aspects. Nicole, as a developmental psychologist, led the social aspects, and then a certified mindfulness instructor led the mindfulness aspects. We also worked with ASU speech and hearing department to incorporate SLP trainees as well as a supervisor into the program, which really is a testament to the amazing opportunities for students at ASU to get involved in research. And our final sample demographics are here. We ended up with about 10 participants in each group, give or take. We purposefully recruited a broad age range representing 20s to 70s, about a 2-to-1 male to female ratio, average intellectual functioning, and all autism diagnoses confirmed with an ADOS. So feasibility and acceptability, or otherwise said, can we do it and do people like it? We found very strong results with feasibility, very high fidelity of implementation, and an acceptable retention rate. Acceptability was mostly assessed by a questionnaire where we asked people to rate statements about the course on a 1 to 7 scale, 1 representing strongly disagree, 7 representing strongly agree. And numerically, our participants in the strengthening skills program, on average, rated the program 6.5, so nearly a perfect 7. And the standalone peers rating was on average a 5.9, so about a 1-point drop from that perfect rating. Statistically, this means that the strengthening skills program participants rated their program significantly better than the standalone peers, so showing that people really enjoyed the 3-component approach rather than focusing just on social aspects. And then efficacy, does it help? The 2 areas we targeted for efficacy were an adapted behavior assessment system, which got at a measure of functional independence, so assessing people's conceptual or cognitive aspects of independence, social aspects, and then practical aspects of being independent. Then the World Health Organization Quality of Life Assessment, which evaluated physical health, psychological or mental health, social and environmental domains. Okay, this is a big table that I'm going to break down for you nice and slowly. Each row is one aspect of either adaptive behavioral skills or quality of life. And then we have columns where we compared the strengthening skills program to delayed treatment control, and then columns where we compared the standalone peers to delayed treatment control. So we have p-values, but a little bit more important to focus on is effect size. The strongest effect for both groups was improvements in the ABAS social domain. And this is exactly what we would expect since both groups got the adapted peers components. But from here, the improvements really only came from the strengthening skills program. So the ABAS conceptual or cognitive domain, which contributed to an overall composite score, improvement of a medium effect size. We saw that only in the strengthening skills program. And this is likely because of the cognitive compensation piece that was adapted from the habit program. And then down at the quality of life, we saw large and significant improvements in the psychological or mental health quality of life, medium improvements in the social quality of life. And this is probably related to the mindfulness aspects that the strengthening skills participants received, whereas the standalone peers group did not. So final conclusions from both directions that my lab takes is when we're looking at longitudinal cognitive and brain aging, we see that many autistic adults have persistent and or worsening cognitive, mental health, and social communication challenges with age, so things that need to be addressed. And then from the support program side, we feel like we're onto something with this multi-component support program that aims at strengthening skills in these areas to ultimately improve independence and quality of life in autistic adults of any age. So hopefully we can continue on with this approach, evaluate this in larger studies, multi-site across the country, and ultimately make this a care option for autistic adults. And this is my amazing lab at ASU and all of our incredible collaborative partners, participants, and funding that makes this happen.
Thanks for a great talk, Blair. You're getting lots of applause and floating hearts. So great and fascinating work as usual from both of you. We'll go to the questions in a moment. But I guess my question, just briefly for both of you, is you're both doing some really exciting work, and your work complements each other very nicely. Because it covers the whole lifespan of an autistic person. But and I'm wondering if you think we are yet at an inflection point where we are really thinking about the needs and services for autistic people and their families across the lifespan, or are we still stuck in a pediatric model of autism? So I'll open it up for a quick answer from either of you.
I want to hear Nicole's thoughts first, since she's more of a lifespan person than I am. I'm kind of stuck with adults.
Sure. So I think the Academy is starting to think about a lifespan approach, but I don't know that we have seen this trickle down into practice, unfortunately. And so I think there's still a lot more work to translate the research that Blair and other groups are doing to look at autism and look at aging, because so little has been done there, and so it sort of makes sense that we would have not seen it yet as translated into practice. So I think there's certainly more work to be done.
Great, thanks. Blair?
So I'll speak kind of from this perspective of the adult lifespan, right? Because we're talking roughly 18 to people being 80 years old. And in Nicole, in our work together with Strengthening Skills program, as noted, we took an approach where we included adults basically of any age, which has not traditionally been an approach. People focus on young adults, a very small number of people focus specifically on middle age and older adults. And we see that our approach was more effective in our pilot study than programs that focus on these kind of segregated age groups. And in practice, I can attest to, sitting in on some of these groups and seeing these like intergenerational benefits of middle-aged and older autistic adults being in the same group with younger autistic adults, sharing the strategies that they've worked so hard to develop, and kind of providing this mentorship to younger autistic adults that otherwise wouldn't be available. So I really think that we benefit from including adults of any age together, as opposed to continuing to segregate out. Let's keep kids separate from young adults, separate from middle-aged and older adults.
Great. Thanks for those really thoughtful and insightful answers. So there are a bunch of questions in the chat box, and I'm going to start reading a few of those. There's a question from Wendy. Says, regarding the 40 to 70-year-olds who reported social communication issues, could it be due to the lack of diagnostic tools, support, and programs when they were children, which might have taught them social skills instead? Blair, I guess that's for you.
Yes, that is a great point. And I could talk for a long time about the importance of longitudinal research in autism as opposed to just cross-sectional approaches. So briefly, cross-sectional approaches is where we take one time point of data from people across a broad age range and say, if they differ, then it's because of aging. And for autism, that there's so many other things that older adults have experienced differently than younger adults besides just their age. The world they grew up in, autism was not something that was well identified or that services were well provided. So it's really, it's a start to look at how older adults report on their challenges compared to younger adults, but it really is the gold standard to follow the same people over time longitudinally to really tease out what effect is aging having on autistic individuals, as opposed to just what's the difference between people that grew up in such totally different times with respect to autism.
Great. Thanks, Blair. Nicole, anything you want to touch on that, or just leave it to Blair?
I thought what she said was great, so I'll leave it to Blair.
Okay. A question from David. He asks, as autistic adults age and their parents pass on or become less able to care for them, have you looked at the differences for those whose parents have died and for those whose parents are still able to provide care?
The short answer is no, that we are in just the absolute infancy of trying, especially, more from like a large scale public health perspective, understand the experiences of autistic adults and how environmental factors like where they're living, who's helping provide support, is interacting with aging outcomes. So this work is happening with complementary approaches like what I do, working with individuals with autism that we're directly talking with, and work that others have done with like large scale claims charges like Medicaid and Medicare, but very little is known right now.
Great. Kyler asks about IQ tests and asks whether they've been refuted as a bias measurement tool, and if, whether or not that's the case, how and why are they still being used to evaluate folks in research?
You want to go first, Nicole?
Oh, did you say, do I want to go first? Sure. So there are definitely limitations to all assessments that we use in research. They all have limitations and can be biased. I think we generally use them to help to characterize our samples and to understand, what are sort of the general abilities of the samples that we are recruiting and conducting this research on. And we use them in tandem with several other variables. So adaptive functioning, for example, and report of social functioning and social challenges. So I don't know that I would say that the validity of IQ tests have been refuted. I think it's sort of been acknowledged that there are limitations to them, in particular in populations like autism, where other challenges beyond IQ might make it so that an individual perhaps cannot complete an IQ test like someone without autism would be able to.
Yeah, I think Nicole really touched on kind of the main thing that I would say is that these all have limitations. I'd say probably the number one complaint that I get from people who do our studies is the measurements are frustrating. And that's totally, absolutely right, because they were not made for autistic people. And that could be IQ or depression or, a whole host of things. And it's the curse and the blessing of research that we do these measures that have been validated and standardized, and it goes like a snail's pace to move into updating and specializing measurements for different people. But I can assure you that participating in this work now will only help us get to a place where measurements work better for autistic people.
Great. Thanks. We've got about 5-10 more minutes, so please keep your questions coming. We've got more questions in the chat box. Logan posits that ABA therapy can be a source of trauma for many autistic people. And in looking at outcomes for aging autistic adults, such as memory and mental health, have you looked at differences between individuals who were treated with ABA therapy versus those who have not? It's a tough question.
Nicole, do you want to start with a broader ABA?
Yeah, sure. I can speak to this. So historically, there have been some concerns about how ABA began and how it initially was delivered. I will say that ABA today is so different from ABA of our history. So for example, I was talking about pivotal response training. That is a technique that was derived from ABA. And, I would invite anyone with concerns about ABA to come to take a tour of our center and observe sessions, because they very much look like play. They're focused on naturalistic interactions. I personally am unaware of any research that has looked at aging outcomes between individuals who received ABA and those who didn't. I'm not aware, Blair, maybe you are, but I think some of the challenge here is there is a huge cohort effect, which speaks to one of Blair's responses earlier, that individuals who are, probably in their 40s and older never had exposure to ABA. And so it would be difficult to look at their aging trajectories. This certainly could be something that could be looked at in the future, but then it would also be compounded because now we're seeing such different variations of ABA compared to what we saw historically.
Yeah, I mean, Nicole and I have talked at length about this plenty of times. It's hard. It's, there is this horrible history with ABA and really horrible things being done to autistic kids that were highly traumatic. And that is all very real and true and needs to be addressed and is being addressed, and to move past it, because the function, the principles of ABA are just kind of the way all humans function, that most of us are doing ABA on ourselves all the time in life. We're rewarding ourselves for doing the things that we do good at, and we're trying to change our environment to keep us from doing the things we don't want to do. But the use of any clinical approach really just depends on the quality of the person who is doing it and the education and the community that supports them. And one of the biggest shifts in ABA and autism has been, what are the goals that you're working on? So I think historically there were some really unhelpful goals for autistic individuals that did not need to be the focus, and it was traumatic that they were the focus, things like reducing repetitive behaviors. And now we're hopefully moving to a world where the goals are things that the individual wants out of life and wants to improve skills on. So I encourage anyone who is, helping their autistic kid or adult find an ABA approach that's right for them, be very involved in what are the goals of the program, and that they are actually in alignment with what the person wants out of it. Nicole is totally right that probably as far as aging outcomes, there wouldn't be enough people who had participated in these types of programs that are the age that I focus on But it will become important as people get older and older. And there's just a million questions on what are all of the different things people experience in their life and how does that contribute to aging outcomes, that we're going to have to get much, much larger studies before we can start to answer them. But they're so important.
Great, thank you both. A question from Cecilia about diagnosing teens who may be suspected of being autistic. Where do you go for teen diagnosis? You start at a pediatrician. What's the best path that you would recommend?
I can take this one. I would recommend, you can go to a pediatrician. It depends on where you're located. I know at our center, due to staffing limitations, currently we only provide diagnosis up until age 7, but there are resources in the community here in Arizona where they do provide diagnostics for older individuals. Generally licensed clinical psychologists, developmental pediatricians, in some states, neurologists can provide a diagnosis. So I think it's really finding perhaps an autism center near you, or if you can't find one, you can contact that family resource team that I told you about at SARC. If you're in Arizona, they can definitely provide some recommendations to you in Arizona, or they can provide some recommendations for an autism center in your area who might be able to help guide you.
Great. Blair, anything you want to add to that, or yeah, that covers it. Okay. We've got about 2-3 more minutes. Just looking for other questions. Let's see. Can we share the PowerPoints of your slides? How do we do this usually? Somebody's in the chat box is asking for the information from the slides to be shared.
Yeah, we should be able to do that as long as you can get them to me, and we'll include a link to those either in the post-webinar email that goes out to people or on our website at asuhealthtalks.com.
Okay. There is an ASU specific question, and I'm not sure if we can answer this or provide a referral to Kendra, who's asking, who has a child with autism, originally diagnosed with Asperger's, just graduated from ASU in May. Congratulations, Kendra. Working in their first job. And the question is, are there resources for young autistic adults in the region in regards to social skills, both in the workplace and in relationships? Do we know?
I can take this one. Yeah. So I'm assuming in the region means still in Arizona. So we do offer a couple of programs for adults. We have an individualized services program where it is very much what Blair was talking about, working with the adult to identify their goals. And so it's an approach where they can target anything in the vocational sphere. It could be related to social interactions and social relationships. We also have employment workshops that can sort of delve into some of those things. We offer Peers for Young Adults, which some of the strategies are applicable to social interactions in the workplace. I think that is all off the top of my head, but again, that family resources team will be able to provide you some additional guidance on what we have at SARC, and then also other services in the local area.
Great, thanks. Blair, anything to add to that? Or
yeah, just to add, I don't know exactly where it is in the pipeline, but I know that the developers of Peers created Peers for Careers that is specifically about social skills in the workplace, getting a job and keeping a job. Nicole, I don't know, is that like publicly available?
Not quite yet. So it's still only available through research studies out through UCLA. They have done telehealth research studies in the past, so it's possible that you could participate remotely, but you would need to reach out to them. If you just Google UCLA Peers Clinic, you'll be able to find out more information. But the hope is that that will be coming out in the coming years. So that could also be a good opportunity.
Great. Well, we are at the end of our time together. I want to thank our two distinguished speakers, Dr. Braden and Dr. Matthews. We're getting a lot of nice, so you're getting a lot of nice comments in the question box and a lot of virtual applause and hearts. We will ask you to follow the College of Health Solutions on social media so that you can learn more about opportunities like this one. Our Health Talk series will continue on October 17th, and we'll be discussing the latest updates and resources concerning breast cancer. And you can find this talk. It will be posted soon at asuhealthtalks.com, and that's where you can also register for future talks and learn more about what we're doing. So thank you again for joining us today. We stuck to time. We've had some great exchanges between our audience and our speakers. And this is a space that not only is our college interested in deeply, but Phoenix has become really a cutting edge city for both autism research, but also autism support. So check out SARC, check out First Place, and please stay in touch. And thank you so much for joining today.